Hi, my name is Reid Lombardo. I'm a liver and pancreas surgeon at Mayo Clinic. Today I'm alongside my colleague Dr. Michael Farnell, who is an expert in pancreatic cancer. We're going to have a discussion about pancreatic cancer and its surgical management. Hello, Dr. Farnell.
Hello, Kay. I'm pleased to be here with you today.
Great. So one of the things that patients always ask is, how come I didn't know that this cancer was growing? What are some of the signs that a patient may miss that may identify a pancreatic cancer early on?
That's a very good question, Kay. It can often be difficult to make the diagnosis, but things to look for would be jaundice. So is the urine become dark in color? Has the patient noticed any yellowing of the eyes? Another thing that goes along with jaundice would be itching. If the patient has itching of the skin, that might be a sign, particularly if jaundice is present also. Another thing that can happen would be a change in bowel habit. And if a patient were to have bulkier, oily bowel movements frequently, particularly if there's weight loss associated with that, that might be a sign of pancreatic cancer.
So as you know, that gallstones can block the bile duct and cause jaundice. So what are the key elements that distinguish a benign disease process from pancreatic cancer?
Well, typically, patients who have pancreatic cancer classically do not have pain. So they will get jaundice but will not have pain. So it's painless jaundice is the presentation. Whereas patients who have gallstones, who have a stone in the bile duct, who present with jaundice will typically have intermittent episodes of pain, fever, or chills. And typically the jaundice doesn't get as prominent with gallstones in the bile duct as it does with a pancreatic cancer.
So Mike, if a patient has jaundice, what should their next step be?
Well, I would recommend that they see their primary care physician because there can be medical causes of jaundice. What we're interested in talking about today is mechanical causes of jaundice, such as a tumor in the pancreas. If they see their primary care physician, typically liver chemistries and a hepatitis panel might be ordered to exclude medical causes of jaundice. If there is evidence of gallstones, then perhaps the patient could be dealt with locally in their community. On the other hand, if there's evidence that there is blockage of the bile duct in the pancreas and blockage of the pancreatic duct, that's a problem that really bears evaluation in a tertiary care center like Mayo.
So should the local physician not biopsy this tumor?
Oh, that's a very good question. Actually, that can be meddlesome. It can be technically very difficult to achieve a diagnosis in these patients. And remember, it's the patient with the smallest tumor who can benefit the most from surgery. Trying to biopsy the pancreas can be problematic. There can be false negatives. There can be complications of the biopsy, such as bleeding or leakage of pancreatic juice, perforation of the duodenum. So we would typically not recommend that the mass in the pancreas, if it's present, be biopsied prior to referral. And in fact, we often operate, in fact, most of the time we operate without a tissue diagnosis because the findings on imaging are so classic.
So, to treat the jaundice, I'm going to push a little further. Should the local physician put a stent to open up that bile duct prior to sending the patient here to see us?
You know, that's a complicated question, and it depends upon the level of expertise in the community. Placing a stent in the bile duct is the treatment to deal with the jaundice, and it can make the patient a lot more comfortable. Their appetite returns, their itching is better, their jaundice goes away, and they feel better. But it can be complicated when a stent is placed. If there's a high level of expertise in the local community, a gastroenterologist who's doing this day in and day out, and if there's going to be a period of time before the patient can be seen in a tertiary facility, it would be reasonable to place a stent. However, We don't request that that be done, and if the patient can see us in a timely way, we would actually prefer that minimal, if any, invasive procedures be done prior to referral.
So we know the experience we have at Mayo Clinic. It's very much a team experience for the patient. They're evaluated by not only a surgeon but also a pancreatologist. What should the patient expect coming in to a center like Mayo Clinic? What should their expectations be? Who are they going to see? And are we going to re-image and do an additional test prior to making a decision for surgery?
We very well may re-image the patient. The technology that we have at Mayo is very state-of-the-art. The sophistication of the imaging studies that we have often surpasses that which we receive from surrounding communities. And so we may ask to repeat a CT scan, for example, because it allows us to give the patient a very good opinion about whether the problem that they have in their pancreas is or is not operable.
Okay, so touching on whether or not it's operable, I'm going to ask you to tell me what you would do with 3 clinical scenarios. A patient comes in and based on their imaging at their home CT scan of their home CT, they have tumor that has spread from the pancreas into the liver. Would you offer this patient an operation?
I would not offer the patient an operation for that if it's ordinary pancreatic cancer, what we call ductal adenocarcinoma, which is the most common type that we see. This scenario that you've told me about is called stage 4 cancer or metastatic cancer. That patient would be managed with chemotherapy and not with surgical intervention. If the patient had obstructive jaundice as part of the presentation, then a stent would be placed to relieve the jaundice. A tissue diagnosis ultimately would be necessary in such a patient because potentially curative surgery would not be possible unless the tumor proved to be a very unusual type called a neuroendocrine carcinoma. In those patients, occasionally we will operate and remove the primary tumor in the pancreas as well as the metastasis in the liver.
So is this similar to what Steve Jobs had?
Well, that's the same type of tumor that Stephen Jobs had. He had a pancreatic resection, as I understand it, and then had a liver transplant for the metastases in his liver. So yes, that would be similar.
Let me go back to the patient with pancreatic ductal adenocarcinoma. So suppose this patient presents and they have locally advanced disease, meaning the surrounding vessels are involved with tumor, but it has not yet spread to the liver. What recommendations would you make for that patient, and what are the current technologies that Mayo Clinic have to treat patients like this?
I would recommend in that patient that a tissue diagnosis be obtained, as surgery as a first step is not feasible in such a situation. However, the problem appears still to be localized, and so we do recommend that the patient be treated first with chemotherapy, perhaps with the addition of radiation. Each case is different. Some would receive both, and others perhaps just chemotherapy. Occasionally there will be a very good response to treatment, and the tumor will actually shrink and move away from those arteries that preclude our taking the tumor out safely. And occasionally we can then restage the tumor, that is, repeat the imaging studies, and actually offer a patient an operation a few months later.
You were specific to say the arteries that may be involved. How about if the patient has a vein, such as the portal vein, involved with pancreatic tumor, and no other vessels are involved in the region? What would you offer? You are an expert in portal vein resections. What is the criteria that you use to make an offer to that patient?
If the patient has involvement of a venous structure in the pancreas, the portal vein, the superior mesenteric vein, or the splenic vein, there are techniques that are available for resecting and reconstructing the vein safely. On the other hand, the resection and reconstruction of arteries is not accepted as standard practice. There are a few institutions that are looking into the feasibility of that, but primarily it's the venous involvement that we have shown and others have shown can be performed safely and can give results that are comparable to patients who have similar sized tumors that do not have vein involvement.
So what you're saying is that if a patient have a portal vein or superior mesenteric vein involvement, they may be candidates for surgery.
You bet. We would characterize those patients not as locally advanced, but as having borderline resectable tumors. And borderline resectable means that the tumor is touching up against the portal or superior mesenteric vein, or there's a short segment occlusion, less than a centimeter. In those patients, we would be willing to offer an operation and potentially resect the tumor in block, that is, in continuity with the part of the vein that's involved, and then either sew the vein back to itself, much as you would splice a hose, or if we can't get it to come back together, we would harvest a vein. In my hands, I would use the left renal vein and make an interposition graft to reconstruct the flow in the veins.
You have reported a lot in this area, and so would you recommend patients come to Mayo Clinic to get such a reconstruction?
Yes, I would. This is complicated surgery and should be done, I think, by teams that are doing this day in and day out. The patient should be evaluated in institutions like Mayo, where we have the expertise to identify candidates for such an operation. So yes, that would be my recommendation.
You hit on a topic that I'd like to address before coming back to the patients that are clearly resectable. You hit on the team concept. Describe for me what a patient would experience at Mayo Clinic. Who comprises the team, and why is the team effect so important?
Well, there are two parts to your question. I think team is one thing, and the other is integration. When the patient comes, we try and compress their itinerary in a short period of time so that all of their diagnostic investigations, all of their imaging investigations are done in a timely manner.
And what do you mean timely? Weeks or days?
Oh, within days,
Yes.
Within days. And often the patients that I see have spent a few days being evaluated at Mayo, and we often will offer surgery the day after we see them in consultation. Getting back to team, the patients often will see a pancreatologist in what we call our pancreas clinic. They will have their images done by experts in radiology, read by experts in radiology who really are part of this team. They will be seen by expert pancreatologists, and if any interventions are needed prior to the surgery, like placing a stent,
Right.
it would be performed by expert interventional gastroenterologist. And then the patients are seen in consultation by myself or one of my colleagues who has expertise in pancreatic surgery. When they come to the operating room, they are managed by a team of both surgeons and surgical support personnel, as well as anesthesia and anesthesia support. One thing that I'm particularly proud of is that I have a team of individuals that have worked with me for over 25 years, and we're doing these operations day in and day out, and we're like a well-oiled machine, and we bring a lot of expertise to bear for the patient.
Yes.
And I think my team makes me better than I could be without them. So that's something that I think we offer here at Mayo.
Now, tell me about the percentage of patients that present with pancreatic cancer. What percentage of patients are indeed surgical candidates that do not need to undergo any prior treatment and move straight to surgery?
Unfortunately, the majority of patients who clinically present with pancreatic cancer have metastatic disease upon presentation, much as the patient you told me about that had liver metastases. About 10% of the patients who have pancreatic cancer, when they present to their doctor, have localized disease and may well be candidates for surgery.
So, Mike, what should a patient expect? How long should they expect to stay in the hospital? And what are some of the potential complications that can arise with this operation?
Well, you've touched on the safety of pancreatic surgery, and I'm pleased to tell you that the safety of pancreatic surgery in my lifetime in my surgical lifetime, has improved greatly.
Yes.
When I was training, the risk to a patient's life with a pancreatic resection, a major pancreatic resection, was maybe 20 to 25%. So it was an operation where the patient had a 1 in 4 chance of dying from complications. I'm pleased to tell you that now, in the current era, the risk to a patient's life in an institution like Mayo, where we do this day in and day out, is about 1%. So there's a 98 or 99% chance that the patient will survive the operation. Having said that, we still have a high complication rate with pancreatic resection. It remains at about 40%. So 4 in 10 patients will get some kind of problem after the surgery.
So, Mike, I just want to clarify. You said that about 40% of patients may develop postoperative complications, but these complications are easily managed. Is that what you're saying?
That's what I'm saying. It's rare that we have to reoperate on a patient. Most of the complications can be managed easily with the techniques that we currently have. Actually, the most common complication that we see in patients is difficulty eating, and we feed the patients by vein with hyperalimentation or total parenteral nutrition and wait for the stomach to begin to work again. That's a condition called delayed gastric emptying. That's perhaps the most common problem. You asked earlier about the quality of life in patients, and we touched on the fact that their quality of life is very good. It takes patients, though, about 8 to 12 weeks to really get over this operation. When I talk to patients about the surgery, I tell them it's like trying to get in shape for an athletic event.
Right.
They have to push themselves after the surgery to get up, to move, to try and regain strength and stamina. And it will take a patient, after the vagaries of such a big operation, 2 to 3 months to really get back to baseline. But they can enjoy a great quality of life following a Whipple resection.
So, will this preclude them from having chemotherapy early on? Patients are eager to get postoperative treatment for their pancreatic cancer. So, are they able then to initiate chemotherapy and radiation therapy as recommended?
Yes. Based on our past experience, over 80% of the patients are fit enough about 6 weeks following the operation to initiate their chemotherapy. So the vast majority of patients recover well enough to get chemotherapy when it's indicated.
Now, tell me about some of the current developments that are happening within the Department of Surgery for pancreatic cancer and within the institution.
There's a trend across the world, really, in doing minimally invasive pancreatic surgery. And Mayo is leading the way in that. We have colleagues that are doing, many of us are doing removal of the left portion of the pancreas, called a distal pancreatectomy, laparoscopically. And one of our surgeons who has a particular expertise in minimally invasive surgery is even doing laparoscopic Whipple operation.
Right.
And the results have been very good, and that may well be the future direction that pancreatic surgery goes, much as gallbladder operations
right.
and appendectomies are now done primarily laparoscopically, and there may be a day, not in my surgical lifetime, but maybe in your surgical lifetime, where pancreatic head resections are routinely performed laparoscopically.
And so you would, of course, recommend patients to come here to get their laparoscopic Whipple operations.
Well, there are very few institutions worldwide that have the experience that we have within our section performing laparoscopic Whipple resection, and the results are comparable to open Whipple operation.
So Mike, I still hear a lot of patients come in and say that their doctor thinks that pancreatic cancer is not treatable or that treatment shouldn't be offered. What is your take on that?
Well, we talked earlier about the fact that unfortunately many patients present with disease that is advanced. However, having said that, we have a much better ability nowadays to identify those patients that are candidates for surgery.
Right.
When I was training and we took a patient to the operating room who had a mass in the pancreas and painless jaundice, there was only a 10% chance that we would find the tumor to be operable. With the quality of the imaging that we have today,
Right.
we can take a patient to the operating room knowing that there's about a 95% chance that the tumor will be operable.
Right.
We can see things on the preoperative imaging that heretofore that we were unable to see that allow us to know what we're going to find when we get in the operating room.
And that really is the reason why we want our patients to have most of their imaging studies here, because the techniques available and afforded at Mayo Clinic will allow us to make these decisions very early on in the evaluation.
Yes, and we often do ask our patients to be willing to have some of their studies repeated because of the quality of the imaging that we enjoy here.
I just want to wrap up by asking you this question. Why, in your opinion, would you tell a patient to come to Mayo Clinic? Based on your years of working at Mayo Clinic, tell them what is special about our institution.
Well, that would take me a long time to do because there are a lot of things that are special. We touched a little bit on the integrated practice at Mayo, the fact that the patient's problem is dealt with in a timely and efficient manner. We talked about the team approach and the fact that it's a multidisciplinary approach, so it's not just one doctor that's making the recommendations. Expertise is brought in from all the various areas. The other thing I haven't talked about that I think also plays a huge role is the quality of the nursing staff that we have within our hospital facilities. They are just wonderful. Our hospitals are award-winning magnet hospitals and have received awards for the quality of the nursing care that's provided. And I tell my patients that if my family were sick, I would want them to go to the unit where my patients currently go because of the quality of the nursing staff. And I think that that has a lot to do with the success that we enjoy for our patients following surgery like this.
Thank you, Michael, for joining us today. Your experience is invaluable.
Well, Kay, it was a pleasure. Thank you for having me.
Thank you. And thank you for joining us in our discussion on pancreatic cancer.